Okay, good morning and good afternoon, everyone. Welcome to our special presentation. We are happy to be partnering with the Wyoming Department of Health, and we're happy to have them sponsor this training for us today. We are going to be talking about the MDS changes coming up in October. So I'm now going to introduce Tim Kozad. He's one of our Wyoming Department of Health Office of Healthcare Licensing and Surveyors. So welcome, Tim.
Thank you. So I have the pleasure of introducing our speaker today. Jesse McGill is a curriculum development specialist for APACN. Previously, Jesse worked as the director of clinical reimbursement for a large long-term care organization, overseeing 17 clinical reimbursement consultants across 21 states, including nearly 300 living centers. She has more than 20 years of long-term care experience, including restorative nurse, MDS coordinator, regional clinical reimbursement specialist, clinical reimbursement trainer, and director of clinical reimbursement. Jesse is passionate about developing the skills of nurse assessment coordinators, restorative nursing, and improving residents' quality of life and care. So with that, take it away, Jesse.
Thank you, Tim. It's such a pleasure to be here and bring the important October changes to our listeners. And I just have one housekeeping slide here that I have no disclosures, and I will not promote any commercial products during this presentation. I am going to come off of camera. Just wanted to say hi before we get going, and I'll end my video so we can focus more on the slides. All right, so there are 4 main learner objectives for this presentation. The first is to recognize how the removal of section GG goals may impact workflows and care planning. Next, to identify new coding instructions for septicemia and best practices to secure that supporting documentation. To understand the process for how the team will identify COVID-19 and pneumococcal vaccines that are up to date. And lastly, to comprehend the 4 reasons a manual deletion may be required for MDS corrections. All right, so we're going to get right into the updates and starting at the beginning of the REI user's manual, so we make sure we cover them all. First is chapter 1. There were really minor edits here. There were, wherever there were mentions of goals for section GG, the goal sections were removed, and CMS updated some links. Chapter 2 had no updates. So chapter 2 talks about assessment requirements, talks about timing and naming of different assessments. No changes to chapter 2. Chapter 3, at the very beginning, before they get into the line-by-line coding instructions, we have the coding conventions. There were a couple edits to the coding conventions. First was a removal again of the goals regarding section GG and updated skip pattern examples. When we get into the rest of chapter 3, that's where we start going through the line-by-line updates in the REI. And the first one is kind of a tricky one because when you go through the new manual, you don't see any red lines that would indicate an update because they just removed instruction. And so the instruction they removed is in cases where there's a standalone Medicare Part A discharge assessment. And this is in regard to coding A2121, which is the provision of the current reconciled medication list to the subsequent provider. Now, by removing this, essentially what they did is they removed the requirement to code the reconciled medication list to subsequent provider when the resident ends their skilled stay and remains in the facility. So when you are completing a standalone Medicare Part A discharge assessment in that situation, A2121 is no longer on that item set. So that standalone discharge assessment doesn't even have this item for you to code. So the requirement to do the reconciled medication list and provide it to your own team or to a different unit within your team is no longer a requirement. All on those same lines, another removed instruction from this same area. This just went into a little bit more example, again, with the standalone Medicare PPS assessment. And again, this is only on that standalone assessment when the resident is ending skilled stay and they're not physically discharging from the facility, they're remaining in your facility. And this instruction that I have on the slide was removed. And the impact is the same on the prior slide. When you have a resident who ends their skilled stay, but they remain in your facility, there's no requirement to do the provision of the reconciled medication list to your own team. The next change coming this October is to a new coding tip in the BIMS summary score. CMS added the new coding tip, and this is just a clarification. It didn't really change our workflow or our process. But what they said is if all the BIMS items are coded with a dash, then C0500 BIMS summary score is also coded with a dash. Now, this aligns with our current and previous instructions, and it just clarifies how the summary score is coded when you have to dash the entire interview. So first, let's talk about when you would dash the entire interview. That would only be in cases where you did not assess for the BIMS summary score. So you did not attempt the interview. And this could have happened for a variety of reasons. The resident may have unexpectedly discharged, so you weren't able to attempt the interview, and they all have to be dashed, including that summary score at C0500. It could be a situation where you had a staff member who was assigned to do the BIMS, and she was waiting till the last day and ended up having to leave work early and didn't get it done and didn't tell anybody that it needed to get done. And we didn't realize it was omitted until after the ARD. Something like that, where the resident should have been interviewed, but it was not attempted. That would be you're dashing all the BIMS items and you're dashing the C0500 BIMS summary score. Now, I do want to clarify a couple things with this new coding tip. First is that this did not change the instruction for when you have a standalone 5-day assessment, that you can still proceed to the staff assessment. That instruction is still in the manual. Also, there is still the instruction for the incomplete interview, keeping in mind that a not attempted interview is not the same as an incomplete interview. We still have the instruction to code 99 for the C0500 BIMS summary score if the resident chooses not to participate in the BIMS, so they say, nope, I'm not answering any of your questions, or they refuse or give nonsensical answers for 4 or more of the items. Then you would end the interview after you have the 4 nonsensical responses, dash the rest of the items, but the summary score would be coded as 99, which indicates that the interview was attempted but not completed, rather than a dash, which would indicate you never attempted that interview. The next change to the REI is one that I think a lot of us have been celebrating, finally taking something off of the MDS. And this was the section GG discharge goals being removed. And so essentially what I have up on the screen is just a screenshot from the updated item sets for either your 5-day or your admission, where you have that admission performance in column 1 being coded. Right now, we have 2 columns on these item sets. You have the admission performance and the discharge goals. Come October 1st, column 2, discharge goals, is completely removed. So with this update, you also saw the removal of all instructions for coding discharge goals. We saw the removal of the revision of examples that included discharge goals, where they cut out that part that talked about establishing a goal. And they also revised some skip patterns in some of the pages due to these edits. So what does this change? Coding discharge goals is no longer required on the MDS. That's essentially what changes. And I want to talk about why just briefly. The why behind this change is because the SNF Quality Reporting Program, or SNF QRP, had originally created a measure when we first saw section GG. So if you've been in the field for a little while, back in 2016 is where we first started getting section GG on the MDS. And we had a new QRP measure, was the very first one, where we had to report function and establish at least one care plan goal on the MDS. CMS has now said, okay, you have proven to us that you can report GG data and you can establish one goal. We no longer need to collect this information. So CMS no longer has a purpose to collect the section GG goal information because they ended that measure. But I want to really talk about what did not change. So when we talk about function in section GG and discharge goals, even though it's no longer going to be coded on the MDS, it's still part of the care planning requirement. So this is something that we need to discuss with our team when we're talking about discharge care planning, when we're talking about care planning for functional goals, when we're talking about identifying barriers to discharge and at what functional level do they need to be at to achieve a successful discharge or transition back to the community. Or even just with their care plan, establishing realistic functional goals. And this needs to still be a conversation with the resident and or representative to understand what the resident's goals are for functional ability. And we make sure we incorporate that into their person-centered care plan. So even though the section GG discharge goals are not coded on the MDS, if you have developed a really good process to discuss discharge goals as an interdisciplinary team and you have that collaboration already put in place, I would recommend keeping that in place. Just because it's not coded on the MDS doesn't mean it's not very valuable information for your care planning and discharging goals. So I would recommend keeping whatever process you have to establish those goals in place and continue to use that for your care planning and discharge planning purposes. But again, CMS doesn't need that information anymore, but we still do. There were also some other edits in section GG. The first one being a correction to an example, and this is actually one that our team at Apacan had sent in a question to CMS. So what I have on this slide is the original example where it talks about a resident being unable to complete their personal hygiene and the certified nurse assistant completed these tasks for them. And this was in the manual, the coding was substantial or moderate. And we had submitted the question because it sounded like it was more of a dependent situation where the resident was not able to complete any of those tasks. And I'm very pleased with the new example that CMS put in because they changed the example to be a per episode example. So they actually detailed that there were 2 occasions during the 3-day window where the resident performed all the hygiene tasks independently, and then 6 times where the staff or the helper had to do those tasks for the resident or finish those tasks for the resident. And so they looked at the totality of those 6 occasions, and they said that the resident can usually perform these tasks with substantial or maximal assist. So this was a really good example of using all of the information through that 3-day window to make a determination rather than what we see oftentimes with the section GG examples, which is looking at one episode and determining how the resident performed in that one episode of care, where of course you all know we have to look at that entire 3-day window. So a great replacement on this example. CMS also added and revised some of the coding tips for the stairs items. And the first one is an example where they have a resident who's unable to complete the stairs activities because of a physician prescribed restriction of no stair climbing. And they removed the part where they specified that this should be coded as an 88, not attempted due to medical condition. And they replaced that by the resident, even if they're on this restriction for no stair climbing, the resident may still be able to climb stairs in other safe means, such as a stair lift or bumping or scooting on their buttocks. And if they are able to complete the stairs safely in one of those alternative manners, then we code based on the type and amount of assistance required to complete that activity. So just an added clarification when the resident can do stairs in a different method, or if they have a stair lift. Another 2 coding tips that were added to the stair items. The first one talks about if the resident is on a physician prescribed bed rest. Now, this is an important distinction between the previous one, which was a restriction specific to stair climbing, which the resident was still able to use an alternative means, perhaps use an alternative means. Here we have a prescribed bed rest, which means the resident's not bearing any weight and they're not able to attempt the stairs. And this is where they say use one of the appropriate activity not attempted codes, because we're not able to attempt the stairs if they are on a bed rest status. Now, the important distinction between the 88 not attempted due to medical condition or 09 not attempted due to the activity was not applicable to the resident is whether or not the resident could complete this task prior to the current illness, exacerbation, or injury. So if the resident could do stairs before, but cannot now because they're on bed rest, that would be an 88. They're not able to attempt it because of their current medical condition. If they could not do stairs before and they cannot now, it's a 09. They're not applicable because that task didn't apply before and does not apply now. The next new coding tip that CMS added for stairs is while the resident can take a break between ascending and descending the 4 and 12 steps, they must be able to ascend or descend all steps by any safe means without taking more than a brief rest break to consider that activity complete. So when it comes to what is a brief rest break, that's something that your team will have to use clinical judgment to determine if it is a prolonged break that would be would end that ability to complete that activity, or if it is a brief rest break that you can still consider that activity completed. So again, that's a clinical judgment during that task that you'll have to make that decision on. And the impact of these new coding tips is really just to clarify coding. But I would recommend that you share these new stairs coding tips with your therapy team, who may often be doing the stairs or step items in the therapy gym, and making sure they're aware of these new coding definitions so that if the resident does take more than a brief rest break, they can put that in their notes so we can use that information for making coding determinations. The next update is on external catheters. And here we saw a very good clarification on female external catheters. Previously, we had a very specific type of external catheter for females that was really limiting in the description. And here we have more of a generic description of other non-invasive urine output management devices or systems that route urine to a drainage bag. And that last part of the clarification is really key, that it has to be a type of external catheter that does route drainage or urine to a drainage bag. And this allows for use of some newer devices such as the wicking systems that wick urine away from the body and into a drainage container, drainage bag, and allows for more just a generic broad view of the external catheter, so it's not so limited. So this was a really good REI manual update that really just clarified it so that new devices can also be included when we use other types of external catheters for females. Oh, this next one, septicemia. This is the one that I would say took me by surprise the most. It's not something that we expected to see in the manual. It's not something we really had heard a lot about. But it was definitely something that caught our eye when we saw this update in the 1.19.1 REI update. And that is the new coding tip for septicemia. This is on the new REI manual page I-13. And the new coding instruction or coding tip states, for sepsis to be considered septicemia, there needs to be an inflammation due to sepsis and evidence of a microbial process. If the medical record reflects inflammation due to sepsis and evidence of a microbial process, we can code sepsis at I-2100 septicemia. If the medical record does not reflect inflammation due to sepsis and evidence of a microbial process, enter the sepsis diagnosis in ICD-10 code and item I-8000 active diagnoses. Okay, I went through that pretty fast, but I'm going to break it back down because there's a lot of stuff here to unwrap. First, If you have a physician diagnosis of septicemia, you're good. Check the box at I-2100 septicemia. If you have a diagnosis of sepsis, up until October 1st, we've been always told just check that. Sepsis and septicemia are very closely related. Septicemia is typically the infection that usually results in the sepsis condition or presentation of those symptoms. And so it was always acceptable to code sepsis under septicemia. But CMS, effective October 1st, is adding more information that must be collected. So consider this kind of like with the UTI item, where we have the diagnoses, but we can only code it on the MDS if we also have these other criteria met. So we have to have medical record documentation of inflammation due to sepsis. Now, I want to talk about inflammation first, because when we're talking about sepsis, we're talking about a multi-organ response to a bacteria or microbial process in the blood. So we have a multi-system response of inflammation here. So this could present as a fever or even as a low body temperature or hypothermia type symptoms. This can result in a rapid heart rate, abnormal breathing, intense fatigue, pain. You could have the chills, cold sweats, shaking, clammy skin, redness and swelling. You know, when you look it up and you really look at the different types of ways that inflammation presents itself with sepsis, there's a lot of different ways from heart and respirations to even skin rashes, confusion, agitation, mental status changes. And so it's important when you're working with your nurses and you have residents that come in with a diagnosis of sepsis, that they are aware to be assessing for and documenting on inflammation. What signs and symptoms of inflammation are being presented for this resident based on their sepsis? And it can present in many different ways for different residents, especially if it is at its most acute stage or if it's more towards the end of their sepsis and infection. And so again, having those nurses know and assess for and document on any signs and symptoms of that inflammation will meet that first part of this criteria. The second part is the microbial process, which we may be reaching out to the hospital to get lab reports to support that there is a sepsis going on, reaching out to the physician if we need to get that supporting information. And if we don't have the ability to tie directly the inflammation that connect that the inflammation that's being presented is due to the sepsis, that's something we might be able to reach out to the physician for and have clarified, especially if the resident has other types of diagnoses that may have inflammation symptoms. We want to be able to distinguish what is the new onset of inflammation that is related to the sepsis versus what is the other disease diagnoses input. So two things we have to code sepsis under I-2100, that check box for septicemia, is the documentation of inflammation due to sepsis and evidence of a microbial process. You have to have those two things. If you don't have those two things, our instructions say you can still code it, but not at I-2100. You can code it at I-8000 additional active diagnoses. And so this is one of the ones where I would recommend a little bit more documentation when you are completing your MDS. Just a quick note to clarify, sepsis was coded as such on the MDS either due to the presence of the documentation or the lack of documentation, so that it's really clear when anybody else is reviewing your record how you came to your coding decision to support especially this new coding instruction, because these diagnoses that have these additional requirements, and if you have someone looking and they're digging for information and you found it in a kind of a remote spot in the assessment or in only a couple nurses' notes, you want to be able to point to that documentation to support how you coded that assessment. All right, so the next edit is on feeding tube. And I realized when I sent out my slides that I did have fluids in there twice. So fluids used to be on the other side of the medication, which is now crossed off, and I had to move it over. So you can see that edit on your slides. But essentially, in the definition of feeding tube, CMS removed medication. And so now, instead of a tube that can deliver all of these things, including medication, it's only a tube that can deliver food, nutritional substances, and fluid directly into the GI system. And so with this instruction, I would take this to mean if the feeding tube is solely used for medication administration and not for food, nutrition, or fluids, then I would not code it. Only code if it is used for food, nutritional substance, or fluids for for K0520. The next revision was also in K520, but for parenteral or an IV feedings. And this was an important update because it clarified something that was kind of a widespread understanding, but there was that one coding tip that said the fluid intake, it has to be specifically for nutrition and hydration. And you can see there on the second line, CMS added a /or. So the parenteral or IV feedings have to be specifically for nutrition and or hydration. And so they did just clarify that. And I think that's typical coding practice, but this one statement did make that a little bit tricky, and CMS did clarify that with this change. All right, the next coding change is a new item, anticonvulsants at N0415 under our high-risk medication. And so this is just another medication classification in that long list of the medications we have to look up already. And so here we're checking if an anticonvulsant medication was taken at any time during the 7-day look-back period or since admission entry or re-entry of less than 7 days. What that second part of that statement means is we can't go past that pre-admission barrier, so we only look back 7 days. And if the resident had an entry or re-entry within those 7 days, we stop at that entry. So it might only be 4 days if our ARD is set that close to when they came back from a hospital stay or a new admission. And so again, we're checking the anticonvulsants only received in the facility by pharmacological classification. And we also have the coding instructions for N0415K2, which is where we check if there is an indication noted for the anticonvulsant medication that was taken by the resident during the 7-day look-back period. An important note, and this is something that we did clarify with CMS last year with when they switched over to the meds and the indication of use, is that documentation of indication of use does not have to be within that 7-day look-back period. When you talk about residents on medications, they might be on medications for a very long term in some of these categories. So the original documentation of why the resident was receiving it might have been months or longer ago. But that should be something that is reviewed by the physician during their routine visits and confirm that they still need that medication for that indication of use, especially for these high-risk drug classifications. So how does this impact our workflow? It adds another additional drug classification for MDS monitoring. So it's another type of drug class that we have to become very well aware of. And why is this important? One of the things that is very clear when we look at the state operation manual, which is the guidance to the surveyors when it comes to the federal regulations, and looking at Appendix PP for this, is there's often times that anticonvulsants are used in place of antipsychotic medications. And so when other medications may affect brain activity, and it goes on to say in the SOM, lists several different types of medications, including the anticonvulsants, that this can only be given with a documented clinical indication consistent with clinical standards of practice. And we must monitor these types of medications for any adverse consequences, especially increased confusion and over-sedation. There's also more in the state operation manual when it talks about when you have replaced an antipsychotic with an anticonvulsant, we still need to go through the gradual dose reduction review process with that anticonvulsant, since it is replacing an antipsychotic medication, ensuring the resident's on the lowest dose possible, or if it can be eliminated eventually, that is done, unless there is, of course, the contraindications. So very important that we're monitoring the antipsychotic drug uses and that we are treating them as one of those high-risk drug classifications for anticonvulsants, since they do have that effect on brain activity. Another coding tip edit in N0415, and this was when it talked about using anticoagulants to flush IV access. They had the word port in there, and so it did kind of limit that flushes to keeping the port patent, and it's not their intent, and so they did remove the word port, so it is looking at keeping that IV access open during that time period. But again, the clarification is still the same. We do not code the flushes for anticoagulants, just to keep the IV access open. Another coding tip for IV access, for 00110 IV access, is that if a resident has the AV fistula, that does not meet the definition of IV access for 0011001. And again, just a coding tip, that's one of those items that when you look at the instructions and how they define IV access, it can be confusing. So CMS did put this in. Of course, when a resident has the AV fistula, we would capture that under the dialysis item. All right, and then we had some updates to the pneumococcal vaccination. And this is one, it's going to tie right into COVID-19 vaccination updates when we, which is our next one. And when we look at these, how we code the pneumococcal up to date, we have to first know what's up to date. And so I wanted to put these all on these slides because there was enough changes with the pneumococcal vaccine updates and what is considered up to date that CMS edited every single example that they had in the REI user's manual. And they added the statement that in many cases that it hasn't been 5 years since their last pneumococcal vaccination, and whether or not the PCV20 is indicated or not. And again, this is dependent on the resident's age, whether or not they received a vaccine before the age of 65 or after the age of 65, and what type of vaccine they received at that time or over the age of 65. So a lot of different indicators to consider when you're calculating or determining the pneumococcal status up to date. But I want to just point out that the examples changed. Here is another example. And again, this one talks about the 5 years again since the last vaccine, and they're not eligible to receive another vaccine yet because it hasn't had enough time lapse. And the next one, they changed the pneumococcal name to a different type of vaccine. And so several different examples. And when we talk about the pneumococcal vaccine, the last bullet point I have on this slide is where you get the up-to-date information on pneumococcal vaccine. And the most important thing when you're talking about the vaccine coding up to date is that you're looking at this assessment ARD reference. So your ARD to the point in time of what the CDC guidance is at that point in time. So we have to keep up to date with the pneumococcal vaccination timing and compare it to what the resident has at that time. So there's several different examples. This one I have some of the new text in the orange, and then the red line through text is what was removed, again, just so you can see how significantly changed some of these examples are. And I don't feel like it's really relevant to go through each example because each individual resident has their own vaccination journey. And so you have to look at that individual resident with their how old they are compared to the timing and what vaccines they've received before, and where we are now with how much time has lapsed between now and whether or not they're up to date or indicated for another vaccine. And so keeping that link up to date, and I would recommend going out to the CDC website for the pneumococcal vaccination timing at least quarterly to make sure that you stay up to date, but you could do that more frequently if you wanted to make sure there's no changes to that pneumococcal timing, but typically we do see at least an annual update with that file. But of course, as new vaccines come out and we may see more vaccines available, and then the changing of those recommendations. And that brings us right into the COVID-19 vaccination up to date, which is a brand new item to the MDS. This is one of the biggest changes we saw when it comes to new items. This one has all new rationale, care planning, all the different pieces of a new MDS item. And like with the pneumococcal vaccine, we're looking at whether or not the vaccine is up to date. And so again, as we go through this, considering that we're looking at a point in time for the vaccination, what is considered up to date, and that is based on the ARD of this assessment. So if there's changes to the up-to-date vaccination requirements, then that does change how we're coding based on that point in time. All right, so the first part of the updates for the COVID-19 vaccination go through the health-related quality of life, and it does talk about the importance of COVID-19 vaccination, as well as how the persons aged 65 or older had a higher fatality rate with COVID-19 and more serious illness from the COVID-19 infections. And then it gets into the care planning, which talks about the strong infection prevention and control process. And of course, that's something that in the facilities, you have dealt with COVID-19 for several years now. And so there are systems and processes for all of the, not just the COVID-19, but the other respiratory illnesses as well. And especially if we're not sure if it's COVID-19 when those symptoms onset. In efforts to increase the number of people who are updated with their vaccines, CMS's goal and CDC's goal is to prevent more illnesses, prevent more hospitalizations, and prevent more deaths. And there's also a really helpful guide that talks about the clinical considerations with COVID-19 and potential side effects from the vaccine, precautions, contraindications. And so the link at the bottom of this slide is from the cdc.gov. And this can be something that you can use when you're talking to residents who may have vaccine hesitancy. So they are very well aware of that serious problems are rare, but what those problems could be, so they can make an informed decision as you go through the risks and benefits of the COVID-19 vaccine with them. The steps for assessment are very straightforward. So essentially, we're asking, is the vaccination status up to date? Oh, excuse me, steps for assessment. We get our information from any available source. So we can talk to the resident, look at the medical record, talk to the family. We might get it from other caregivers, healthcare providers. So really, CMS says we're not picky about where you get this information from. If the resident self-reports that they had the COVID-19 vaccine, then we need to try to find out which type and have that documented in the medical record. If the resident is not, if the resident's not up to date, or the facility cannot identify their vaccination status, then we need to ask them if they would like to receive a COVID-19 vaccination. The coding instructions are really straightforward. This is where we're determining if the COVID-19 is up to date. So we're looking at this point in time, so the ARD and the current CDC guidance for what is considered up to date. And if the resident is not up to date, is regardless of reason. So if they are not up to date due to medical contraindication, they're not up to date due to an allergy, religious exemption, or other types of qualified exemptions, the reason does not matter. It's a simple yes or no. No, they're not up to date, or yes, they're up to date with the CDC's current definition of up to date, which does include any of the required boosters beyond those original COVID-19 vaccinations. CMS also does clarifies that a dash is a valid response. So if you did not assess the COVID-19 status, then you can dash this item. And that can happen in situations, especially if it's a really short stay, resident comes in and discharges unexpectedly within a couple of days, and maybe didn't have time to do that research or ask the family or resident about their vaccination status. And so those situations may occur, but CMS does expect the dashes in this item to be a rare occurrence. So up to date for COVID-19, how do we know what this is? There is a link in the REI Users Manual, but as of today, that link is not working. And so I did include an alternative link on this slide, and we do have a question that we're posing to CMS to try to make sure that this is the right link to use, because the original one from the new REI Users Manual is coming to a page not found. And this is something that's really important, that we're able to locate the correct page on the CDC website and identify what is up to date at this time. And if you go to the next slide, like with the pneumococcal vaccination, there's a lot of things to consider. We have to consider the resident's age, prior vaccinations for COVID-19, and where they are at today with their any boosters. So when we're looking at people age 65 years or older, you're up to date when you have received 2 updated 2023 to 2024 COVID-19 vaccination doses. So 2 updated doses of that one. And people aged 65 or older have not previously received any COVID-19 vaccination doses should choose to get Novavax, and choose to get Novavax should get 2 doses if updated with the Novavax vaccination plus 1 additional of the updated 23-24 vaccinations to be up to date. That's a lot to take in, and so I would recommend printing out the recommendations and then again checking at least quarterly to see if there's any changes with those recommendations. Now I did just review just the people aged 65 years or older, but I know in our facilities we do have younger populations, and across the country there are some pediatric skilled nursing facilities as well that may deal with that 6 months to 4-year-old range. And again, looking at the age of your resident, the prior vaccination status, and what would be considered up to date and whether or not they meet that criteria at that time, which typically indicates if they're not indicated for another vaccine yet, they're up to date until that time lapses, and then they would be not up to date. There are also coding tips on how to stay current with what's up to date. And again, the link that they have in the manual is not working right now, but there are easy ways to search for COVID-19 stay up to date on the CDC website. And that's where I found that alternative link. But again, hopefully CMS gives us an update before October 1st. The impact this has on the facility is this will take a little bit more investigation. We have to interview resident and family regarding COVID-19 vaccination status and be prepared to talk to the residents about the risk and benefits of the COVID-19 vaccinations, and monitor that stay up to date page for changes so that we ensure that we are coding this accurately based on that point in time. And I would also recommend keeping a copy of what is up to date in a binder, so that if you have a surveyor or audit years down the road, or months down the road when there's been some changes, you can go back and you can see what was up to date at that point in time, because sometimes you can't look back on the CDC website to see what was up to date at that snapshot in time. And that's really what we need to know to ensure that it was accurately coded at that time. All right, and the last major update we're going to cover today is on the manual deletion cases. And we saw some updates in section X under the modification request and in chapter 5 where we talk more about the correction request. So section X did add the new item, number 3, for when a manual deletion is required. And this is when you have a record that was submitted that's not for OBRA or Medicare Part A purposes. That's the new item added. That would be in cases such as where you have a Medicare Advantage plan that requires a 5-day that should not be submitted, but you accidentally submitted that and it's not needed. So we're going to talk more about this as we go through a couple slides here. In section X, it also has this new case where it goes into more detail about submitting an assessment for that should not have been submitted because it was not for OBRA or Medicare Part A purposes. And essentially what this comes down to is when you submit these types of records, it is providing CMS information to data that they are not authorized to see. So it's an authority over that data, which is the problem. And when you were, if we were to do a inactivation, that does not remove that assessment from the system. That simply moves it from an active status to an inactive status, and CMS can still access that data. So that's not a proper fix for this type of error. And I'm just going to go on again to next slide, because this gets into chapter 5. So when you're looking in section X, it's essentially saying you cannot use the modification process or the inactivation process in these 4 reasons. You can only fix these with a manual correction or deletion request. And so the 4 reasons are if you coded A410 wrong, which is the unit certification or licensure designation. That essentially is the item that says who has authority to see this data that I'm submitting into IKEYS. And so if that coding is wrong, then you're going to give access to data to people who are not authorized to have it. The second item is facility ID codes, which should be part of your software vendor setup. So if there's an error with that, that's something you have to work with your vendor on to identify the issue and then go through that process. Number 3 is the new one. If you submit an assessment that's not for OBRA Medicare Part A purposes. In the past, this is something that we just did an inactivation for, but now it does require that manual deletion process. And the last one is if a test record was inadvertently submitted, and that again is typically a vendor software issue that would be submitting that test record. I did just see a chat come up asking about entry MDSs, and entry MDSs are over required. So this is only for if you have a Medicare 5-day for a Medicare Advantage plan, and that Medicare 5-day should not be submitted because they're not on traditional Medicare Part A. So CMS does not have authority to that Medicare assessment data. OBRA requirements for that same resident require us to do the entry and the admission, and if they're staying in our facility, a quarterly. Those are all OBRA required assessments. But for the 5-day assessment, which is used for billing only, if it's for a Medicare Advantage plan, you cannot combine that with your admission because that 5-day assessment cannot be submitted. So that's a really key distinction. And the process for manual deletion is quite intense. So the only way to go through the manual deletion process is to reach out to your MDS automation coordinator. And those people for your state are listed in Appendix B of the RAI users manual. And that's the same list that has your state RAI coordinator. It also has your state MDS automation coordinator. And the MDS automation coordinator, you have to contact them and you have to ask them for the manual deletion form. They will send you the form. You have to fill out the form, and it does have patient healthcare information on it, has protected information on it. And you have to mail it through the United States Post Office, certified mail. And those instructions are right on it. The address that you have to mail it to is on it. And you have to say exactly which assessment needs to be deleted from IKEYS. So labor-intensive process. I would recommend having a check and balance system before you submit your MDSs to make sure for number 1 and number 3, because the other 2 are more vendor issues, but for number 1 and number 3, make sure A410 is coded correctly based on the licensure of that bed. So if your entire facility is Medicare and Medicaid certified, then you're always going to choose that option for A410. If you are only Medicaid certified, or if you have units that have different certification, you have to code based on the certification of that unit that the resident resides in. And then again, I talked about the record submission. All right, and then it does go through a couple other examples and talks about this a little bit more with the fact that CMS doesn't have the authority to collect this information. Appendix A, which is the glossary, also had some updates, and these are just new additions to the glossary. We already talked about the external catheter. They defined indication and added that to the glossary, and then up to date for the COVID-19. But again, they included the link there, but that is the link that does not work at this time. And then a couple small updates to the Appendix C call worksheets. Not a real change here because anticonvulsants was already listed, but since it's now an MDS item, it has now the MDS item listed on it as well for mood and dental. And another major change with how the MDS is set up is the matrix used to be in Appendix F in the manual, and now it's a separate document so that CMS can update that separately without doing an entire RAI manual update change. And that is listed in the download section on the RAI manual webpage. I have that link there. All right, that was a lot of information in a short amount of time. It looks like we still have about 10 minutes for questions. So let's open up for some questions.
Feel free to drop your questions in the chat, or if you guys would like to, and you're comfortable to do so, you guys can come off mute and ask Jessie your questions now.
Hey, Jessie, this is Carrie.
Hi, Carrie.
Hey, going back to section GG, when we determine, you were talking about like the stairs, if they could do it before, then, and can't now, we code 88. If they couldn't before and can't now, that's 9. How do we determine what before is when we're a long-term care facility that has patients that have been here for like 10 years?
Oh,
Is
that
it
is
past
a great
MDS?
question. That is a great question and one that we've actually asked CMS to clarify a couple times. CMS usually defaults those questions to the state REI coordinator. And unfortunately, a lot of the state REI coordinators are not really sure how to answer that question either. And so what I would recommend is using your best clinical judgment. Now, if this is something the resident has been able to do for years, I would say that's not applicable. You know, they didn't do it last month, they're not doing it this, or last quarter, they're not doing it this quarter. I would say it's not applicable to the resident, even though there's no major injury, illness, or exacerbation. But if there's been a recent change, let's say they've declined and they used to be able to walk 150 feet and now that they're declining, they're not able to, then I would look at, you know, is there a medical condition going on that fits that? So it's definitely something where I would say use more of your clinical judgment to make that decision and then kind of back it up with your rationale and your documentation. But I think CMS's overall goal is to determine whether or not that activity occurred. And for our long-term residents, it's not as important to know if it was, you know, due to medical condition or not applicable, because it won't impact, you know, they might not have discharge plans or it's not something that we're working towards for goals of prior functioning where they may be able to regain that functioning. So I don't have a great answer for you, but I would say, you know, do your best, justify it with your clinical documentation to determine whether or not it's really not applicable for this resident or they've actually had a decline that has been impacted due to a medical condition.
Okay. Tim, I know you're on. Do you have anything to add to that?
Oh, we actually have some questions out about some of that information as well to CMS. So if I get an update, I'll let everybody know.
Thank you.
That's great to know, Tim. Thank you. There is a question about Wyoming Medicaid in the chat. I think that one has to go to Tim.
For some reason, I can't see the question. What is it?
Right, the question is, for Wyoming Medicaid, when is the transition to PDPM occurring for Medicaid reimbursement?
So obviously, that's not healthcare licensing and surveys. That's I don't have any updates on that. All I know is that they are hoping to have it transition soon. They're working with, I forget the name of that group, and Amy Guyman will, update when they're ready to make the transition.
Hey Tim, it's Jordan. I called you a couple of weeks ago about trying to submit the MDSs with the new system that we're using. And when I went to submit, it continued to give me like fatal error codes because the PDPM. And when I called WellSky, they had said that those are the error codes that they were receiving for other people that had transitioned to PDPM. So I'm curious if Wyoming has already done it, because once we switched everything in WellSky to us doing PDPM, everything is submitting through iKeys correctly now without the fatal errors.
Thanks for that information. Yeah, I mean, possibly I'll try to reach out to Amy. Like I said, it's actually a Medicaid thing, which is a different agency than ours. So I'll see if I can get updates.
I don't see any more questions coming up, but I did want to share that some of the resources I used for this presentation, of course, the updated REI Users Manual, and then the COVID-19 up-to-date resources, and the State Operation Manual Appendix PP, which is where I pulled that information about anticonvulsants from, which is very helpful when understanding why we're coding that on the MDS.